Welcome to Discover Health, a White Mountain perspective. I'm your host, Dr. Tom Barela. And we have a most interesting program today, a program that probably will touch almost everybody's lives. We're going to talk about the opioid crisis. And today, our guest is Dr. Don Teater, a North Carolina physician who has come to Show Low to give our physicians and our general population some education. He is a family practitioner who in about 2004 recognized the opioid problem in his own community and started with a clinic. As a result of that, he received some national notoriety, and from 2013 to 2016, he was an advisor to the National Safety Council. This, of course, led to a facilitator role in 2016 with the CDC, who was developing guidelines for prescribing opioids. We're incredibly happy to have him in our community today, and even more so to be on our program. Dr. Teater, thank you and welcome to our wonderful community in the White Mountains.
Thank you for having me.
We read a lot about the opioid crisis in the United States from our president, from national news, from local news, and everywhere. It obviously is a world, statewide, countrywide problem, and also in our community. Just how did we get here? How did we get to this problem?
So there was a lot of things that happened really around the same time. Much of it, I believe, was actually driven by the pharmaceutical industry. And I have lived through this, so I experienced much of this myself. When I started practicing medicine in 1988, we just didn't have a lot we could do for people with chronic pain. We would recommend exercise, we'd do some physical therapy, but there wasn't a whole lot we could do. With a lot of influence by the pharmaceutical industry, in particular a number of companies, Purdue Pharma being the infamous one, they marketed the opioids to us saying, here's a medication that will get rid of your patient's pain, and if they are taking it for pain, they will not get addicted to it. So it's safe, it's very effective, and you should be using it. And then they would share us videos of patients who felt so much better. They actually marketed a number of the specialty organizations like the American Pain Society and helped them develop guidelines for treating pain that recommended opioids. They worked with state legislators to develop some intractable pain laws that recommended we use higher doses of opioids. So they had this comprehensive effort. And I think the medical community is partially to blame, but we really wanted something to help our patients, and we believed what we were hearing, that this would be effective pain treatment, and we started using it. And in reality, part of the way opioids work is when people start on them, they do feel better initially. Chronic pain has a lot of issues where people get depressed, they're anxious, and opioids help that initially, but as time goes on, that gets worse. And so as we're starting patients on it, we saw them getting better, we thought, but then over the course of years, we realized they weren't getting better. In fact, they were getting worse. So it was this desire, I think, by the medical profession to help people. It was the pharmaceutical industry really marketing their products. And by the way, they've all made a lot of money off of this. And it was kind of this, just this desire to help people, I think, from the medical standpoint.
And by the definition of chronic pain, you mean pain that lasts?
Right. So chronic pain is defined as pain that lasts longer than 3 months. Generally, that's the definition. The thought is acute pain is pain that occurs from tissue damage or some type of injury, and it goes away when the tissue heals. Chronic pain is the pain that persists after the tissue heals. Oftentimes, it's hard to say exactly where it's coming from. So chronic pain is really quite a bit different from acute pain. It's also much harder to treat chronic pain than it is acute pain. So they really are kind of two different things, but the chronic pain is the pain that persists when it shouldn't any longer.
And you say that you're not getting better when you think after a long period of time. Why is that?
So there's a number of things that can lead to chronic pain. Interestingly, one of the things we found out is the use of opioids for acute pain greatly increases your risk of developing chronic pain from what you were taking it for. So if you have an acute back injury, and it's been shown that if you take an opioid for acute back injury, it doubles your risk of being disabled later and developing chronic pain. So it's because of the way pain works in your brain, the opioids work on our brain. when I was in medical school, I'm sure when you were in medical school, we were taught that our brains form until we reach young adulthood, 20 to 26.
Correct.
And at that point, our brain doesn't change anymore. Brain cells die, but we don't make any more. And basically, our brain is pretty static. We now know that as people get pain, their brain pathways start to change in ways that cause increased anxiety, increased depression, increased ongoing pain. And opioids also change the brain in ways that are very similar, actually. So we know now that there's brain changes that contribute to the development of chronic pain.
I was reading that there's research now that the brain does in fact continue to grow as we age.
Yes.
Rather than like me going away as I get older, the brain is still has chance to regenerate some things
Right.
and make some new things. Is this any part of the mechanism of maybe tolerance, or I don't really understand. Maybe the
Yeah.
best question to ask you is what is addiction? How does it occur? I mean, I'm sure our audience really has no idea of what addiction really
Right.
means, other than you're dependent on something.
Right.
But why?
So addiction comes from any substance or any activity that stimulates a chemical we call dopamine in our brain. When dopamine is stimulated, it makes us feel good. It makes us happy. Dopamine is stimulated when we fall in love. Dopamine is stimulated when we have sex. Dopamine is stimulated when we eat a really good meal. When our team wins the big game, that really good feeling, that's dopamine stimulation in your brain. All addicting drugs also stimulate dopamine. So people take these drugs and they have this really good feeling. That's the dopamine stimulation. All addicting activities, people that get addicted to certain activities like gambling, they get addicted to that dopamine stimulation when they win. Opioids are a little different. Opioids stimulate dopamine so we feel good, but they also activate the opioid receptor. Our opioid receptor is the chemical receptor in our brain that is stimulated by our own endorphins. And endorphins are a chemical that our body uses in a number of ways. Our opioid and our endorphin system is important because they help us achieve a goal, and they do that by several ways. When our endorphins activate our opioid receptors, we have more confidence, we have more motivation to do whatever we're doing, we enjoy being around people and working with people more. We do have kind of a good feeling because that stimulation does also stimulate a little bit of dopamine. So you think about runners that are running and they talk about this endorphin surge they get near the end of the race when they feel really good.
Second wind.
Right, second wind kind of thing. Well, that's the endorphins kicking in that's giving them more motivation, more confidence they can do what they do, this happiness about what they're doing, this desire to make it to the end. So it's really important, this opioid system. One of the ways that it's really best seen in public and in current culture is everybody has seen the Wizard of Oz story, where Dorothy and her friends are in the woods and all these bad things have been happening to them, right? The witch is throwing fire at them, the trees are throwing apples, the monkeys are flying after them. It's a scary place. Dorothy is lonely. She's missing her family. She just wants to get home. So it's this dark, scary, lonely place. And suddenly they come out to this field of poppies. Poppies contain opium that stimulate the opioid receptor. And you remember their initial reaction. Immediately, they have this happy feeling, this motivation to make it to Oz, this excitement. They have this feeling of interpersonal bonding, so they link arms with their friends and they go skipping and dancing down the yellow brick road. That's our opioid receptor. That's the flooding of the opioid receptor by opium. And so it gives you a good feeling like all addicting drugs, but it also gives you this confidence, this motivation, this happiness that other drugs don't. And because of the dual effect on dopamine and the opioid receptor, we believe that the opioids are it's the hardest addiction to stop. Because the other addictions, you're stopping and you're having this deficiency of dopamine and you're not very happy and you might have some cravings, but with the opioid receptor, you have all these other things that have been damaged, and it's very hard to stop the opioid addiction.
Wow.
So I call that the Dorothy effect, by the way. Let me just go a little further with that.
Okay.
Because so I still do addiction treatment. I still see patients one day a week. And many times what I hear from my patients is they'll say, I grew up in a household where our dad abused us. It was a scary place being at home. I also didn't do well in school. So I didn't enjoy school. I struggled in school. I dropped out in the 11th grade. Because of that, I could never get more than a minimum wage job. I have a hard time paying the bills. My life has always been tough. Then I sprained my ankle. The doctor gave me a Percocet, and immediately I had this renewed confidence, this feeling that everything is okay, this motivation to be successful that I had never felt before.
So the real question is, from what you describe, can the cycle be broken?
So yes, obviously we've got a huge problem in our country. The CDC has shown that life expectancy in the United States has dropped over the past 2 years. The first time that's ever happened, and they attributed that completely to the opioid overdose problem. So the opioids are reversing all the other advances we're making in medicine, right? So, we've got this tremendous problem, and how do we stop this from going, right? So
Right.
I really think there's two key things. There's many things we need to do, but there's two key things we need to do. The people that are addicted already, we need to make sure that treatment is easily accessible, that when they're ready for treatment, and not everybody is ready. They have to go through their addiction for a while before they're ready. But when they're ready, they can get into treatment right away. Because many times just waiting to get into treatment, people can die, or people can have,
Or get into trouble.
Or get in trouble, exactly. Develop a criminal record that follows them the rest of their life. So addiction needs to be readily available all over. That's one key. The other key is we need to prevent people from getting access to these medications. We need to prescribe many fewer so they're not out there. Clearly we have a heroin and a fentanyl problem now, but most people taking those drugs started with the pills in the first place. So we need to greatly reduce the number that are out there so we're not talking about this problem 10 years from now.
So, part of that really is controlling access, and then the other part, which I know you're thinking, is how to not start them in the beginning.
Right. Yes.
And that really comes a lot from physicians, does it not? Physician education.
It does.
I notice now our state here has a registry for essentially controlled substances that now is requiring us physicians to check patients on that registry before we prescribe, so that we know whether they're essentially opioid naive or whether they have been using
Right.
on it for a while.
Right.
The other thing is now there's a training program associated with signing up for that thing, but the training program, interestingly enough, does not approach acute pain treatment as much as taking the physician through the alternatives.
Right.
Is this true in other places that you've been to?
Yes. So, one of my messages that I think is relatively unique is the fact that I do talk about acute pain treatment. More people are starting to talk about that now, and many states are having limits on the number of opioids that can be prescribed for acute pain, and I think Arizona has done that also. But many states have said for acute pain problems, whether it's surgery or an injury, no more than 7 days of opioids. So, it's surprising how many doctors will prescribe 2 weeks or even 4 weeks of opioid medication for an acute injury. And studies have shown that those people have a very high risk of developing addiction from their doctor's prescription. So I think the prescribing limits are good. The CDC guidelines that came out actually recommend 3 days or less for acute pain, regardless of the severity of it, because ongoing use does change the brain in a way that leads them to being susceptible to addiction.
We were talking before we started the program here, my training was that 7 days, you could prescribe essentially 7 days and not have to worry about addiction. And now data is indicating that that's maybe too long.
Right. So the CDC came out with a study just 6 months or maybe 8 months ago where they looked at insurance claims throughout the entire Midwest, and they looked at people that had not received an opioid prescription before, and they had either an injury or surgery and got an acute prescription. And they looked at the characteristics of that first prescription to see if there was any certain characteristics that led to ongoing use and addiction. And they found that people with a prescription for just 1 day of opioids had a 6% chance of still being on opioids a year later. Compared to people that have an injury and don't get opioids, their chance of being on opioids a year later is 0.4%. So it went from 0.4 to 6% with a 1 day prescription, a 8-day prescription that goes up to 18%, a 30-day prescription that goes up to about 30%. So the longer you're on it, the more likely it is to be a problem. And even a 1 day prescription has some risk. So part of what I talk about to physicians is we need to be considering every single dose we give, starting with day one.
Day one. Well, it's interesting because a lot of times in the operating room or immediately after the operation, a narcotic is given.
Right, yes. So that is starting to change now. So a number of studies have looked at what is effective for acute pain after surgery or after an injury. And the studies have actually shown that taking one over-the-counter ibuprofen, that's 200 milligrams, and one extra strength acetaminophen, which is Tylenol, one extra strength Tylenol, taking those together works about 60% better than taking 2 Percocet pills together for an acute pain kind of thing. So we're learning that the non-opioid treatment of acute pain is more effective at pain relief, and it's also much safer in the long run.
So let me ask the corollary to that question. A person who is receiving long-term narcotics, opioids from one thing, because once again, we're talking about how to break the cycle. Can you wean somebody from long-term narcotics to essentially as an acetaminophen and a non-steroidal anti-inflammatory like ibuprofen?
Yes, so you can. So the studies looking at people on long-term opioids have shown that they have a worse quality of life because of what the opioids do to them. Opioids tend to make them more depressed, more anxious. They actually make them feel the pain more in the long term than initially they seem to help, but long term they make the pain worse. So studies have shown it makes them worse, and studies have shown that if you wean people off of the opioids, their pain actually gets better. The problem is not completely better, but about 30 to 40% better. The problem is, as they're weaning off, their pain gets worse during that time. Plus, because of the way the opioids have affected their endorphins and their opioid receptors, it gives them a lot of anxiety and a lot of depression. So they've got the mental issues going on while they're having more pain. So it's really hard to get them to wean off. So when that's done, the studies that have shown success have really been done with the help of a behavioral health specialist working with them to address some of these issues. But it is very difficult to do.
At least, how do we handle that in a small community like ours? My understanding is even in the state of Arizona that those treatment centers, if you want to call them, there's only 5 or 6 in the whole state, and none of these are in rural communities.
Right.
And I know that at least they tell us from the sheriff's department and police department that a lot of the people that are incarcerated in our county are related to narcotics one way or another.
Right.
And obviously, if you say that breaking the cycle is difficult to do, then there needs to be people like you in your small community back in 2004.
Right.
How do we start as a community?
So it's difficult, and it was even difficult, it still is difficult in my community, and much of that I think revolves around the stigma of addiction. We have this stigma that these people make bad choices, that it's a moral failing of theirs that they got addicted, when in fact we know that many times it's the doctor's prescription that led to their addiction. So we need to understand addiction more as a disease. When that happens, people like me, primary care doctors, can get an 8-hour training in how to treat opioid use disorder using a medication called buprenorphine. Buprenorphine works by replacing the endorphins that are missing in the brain. It helps people feel normal again. It takes away their cravings. It takes away their depression and their anxiety, does all these great things. And then have them stay on that, make the life changes they need. And then later in the future, when they're ready, some of them can wean off. Some of them, their brain never gets back to normal. They need to stay on it forever. But this can be done in a primary care doctor's office. My personal belief is all primary care doctors should be treating addiction and should be understanding this, because these people are coming to them for help in many times. And it can be done very easily, very successfully. It is the most rewarding thing I've ever done in my whole medical career, is see people turn their lives around. From going from a place where they'd lost their job, they'd lost their family, they've got a criminal record, they're homeless many times. They come in, we get them started in the medication and therapy, and they turn their lives around and they get all that back again. It is just the most rewarding thing. We need to get doctors to understand how much they can help people by doing this. And again, every doctor should be doing it. In particular, every primary care doctor should be doing it.
Is there any statistics about rise in the prescriptions for that particular buprenorphine?
Yeah, buprenorphine.
Buprenorphine,
The brand name is Suboxone. And yeah, it has greatly increased the number that's being prescribed. But the federal government did a study and believes that if all the doctors that were able to prescribe this were prescribing at their maximum limit, and we've got a limit of how many patients we're allowed to treat at one time, but if we're all prescribing at our national limit, we have the ability in our country to only treat 1 out of 5 people. So we need to greatly expand the number of people, the number of doctors that are providing this treatment.
And essentially obtaining the competence.
Right, exactly.
And
it really is very easy to do. The treatment is very easy. I think it's easier than treating heart disease or lung disease. Again, you're giving them a medication. Your therapist is helping as well. And these people are very grateful people the rest of their lives for what you're able to do for them.
It still seems difficult because that, even in a lot of the education programs for physicians in continuing education, do not approach that strong enough.
Yes.
At least that's been my experience with doing continuing medical education in this.
So here's part of the problem, is that much of the continuing medical education that is developed now is still developed with a lot of influence from the pharmaceutical industry. You know, the main education that's done on the opioid issue is called REMS training, risk something.
Yes.
Evaluation, mitigation, something like that. It's developed by the FDA, but it's developed with input from the pharmaceutical industry. So all of these REMS programs talk about safe prescribing of opioids and how you can prescribe so that people won't get addicted. But in fact, again, we know even the lowest doses can lead to addiction.
Right.
And they also talk about, you know, what you do if you identify addiction and you cut people off. It's not talking about getting them into treatment. So most of the programs that are out there are not talking about the core concerns, like you said, about prescribing less and about doing more treatment for people that are addicted.
Well, that's the big issue right now, is we're already in the addiction. I mean, the problem is already there.
Right.
The question is how to effectively teach us physicians how to break the cycle.
Right.
Is it possible to do without an addiction center like these centers? Is it? I mean, your really contention is that if a physician in our community, we have plenty of family practitioners and internists that certainly could receive that training to break the addiction cycle without us having, and hopefully cut our crime, which
Right.
seems to be highly associated, especially if they're going to cut off through the state monitoring
Right.
program, the continued prescribing of,
Right.
of it. It seems like a very, very difficult issue.
So to answer the first part of that question, I really do think that for opioid use disorder, for addiction to opioids, the best treatment is in the primary care doctor's office. It's not going to an inpatient unit and getting the detox and doing a 28-day program, which are much more expensive also, but they have much worse results. Studies have shown that people that go through a detox program and even live in a residential program for a period of time afterwards have about a 90% risk of relapse in the first 6 months. Only about 10% will stay sober for just 6 months. Whereas people that go to a doctor's office, their primary care doctor's office, get buprenorphine and get therapy, they have about a 50% risk of relapse. So about 50% of them will remain sober after that. So it's about 5 times more effective. People that do relapse will drop out for a while and then come back for treatment again. Again, I've seen this many times. So again, being done in the primary care doctor's office, it's more effective. It is much, much cheaper. And you know, it gets these people also getting all their other health care they need as well.
And you, I mean, that is your program, and that that is the message that you've been
Yes.
giving us. How successful are you? I don't mean to put you on the spot,
No.
but it makes a lot of sense to me.
Right.
Even though I'm a retired guy and never prescribed much opioids in the past.
Mm-hmm.
I mean, are we grabbing it? I mean, it's a slow
process, and
you
we're
got to
getting
get the
there.
early
Right.
adopters in on it.
Right.
And is it
So,
going?
yeah, I think it's improving. It's increasing. We now have we've got the federal government to say that our mid-level providers, like our nurse practitioners and PAs, can also do this treatment. So that expands the availability of people that can get the training. So we are seeing more people doing it. It's still very slow, and again, it's really the stigma we fight. So I talk to doctors and they say, I just don't want to take care of addicts. You know, they're difficult people.
Yes.
They lie. That's a part of their disease. We know lying is a part of the disease of addiction. You know, I don't feel comfortable with that. I don't want them in my office disrupting my other patients. But in fact, you know, it is a disease we should be treating just like any other disease. You know, we treat people with diabetes. We treat people with
Heart disease,
obesity,
lung
heart
disease,
disease. You know,
COPD, yes.
80% of the diseases we treat in primary care are lifestyle related. You know, based on our lifestyle. But we don't give
you don't
people
wanna-
treatment
and
because
it does take a lot of time because you have to have a contract, you have to have
Exactly.
a lot of things.
Yeah.
And it's really and we're getting close to being done. Time went really quick when you're having fun, but in our community, it seems like because we're probably not going to get a treatment center soon, although we're working on it. It sounds like the primary approach that we need to take is educating our great number of family practice physicians, our internists, to be able to use this alternate medicine, and then also to convince our surgery colleagues to not give long doses of narcotics.
Right. And the primary care doctors also. We do plenty of opioid prescribing ourselves. And again, we could get by with doing a lot less and make it much safer for people.
Well, we're essentially out of time, and I've got to thank you for taking time. I know you are speaking to the physicians here in Show Low and have done so, the community of Winslow. And you've been invited by a great number of associations up here, including our hospital and health department and several other community, essentially organizations, who recognize the need to approach the problem. And we as a community recognize that it's a broad problem and want to attack it. And I thank you very much for your time.
Well, thank you.
Those of you that know someone that has this problem, you now know that there are alternatives and there is an approach that we can institute in our community through our physicians. And I thank you for watching.